Hi, this is Manos Brilakis from the Minneapolis Heart Institute and the Cardiovascular Innovations Foundation, presenting video 25.2 for the Manual of Percutaneous Coronary Interventions. This video discusses about how to approach coronary dissection. Dissection is one of the potential mechanisms leading to acute vessel closure, either partial or complete, which in turn is one of the three main complications, coronary complications during PCI, the other two being perforation and equipment loss or entrapment. Acute vessel closure, whether due to dissection or other causes, can lead to myocardial infarction and can also lead to hypotension and hemodynamic compromise, as well as arrhythmias because of the induced ischemia. This is an example of coronary dissections. Dissection is splitting of the vessel wall, which often leads to disturbances in coronary flow. This is a major dissection involving the left main as well as the lady and the circumflex, and as a result is likely to have significant hemodynamic consequences. Some patients do present with spontaneous coronary dissection or SCAD, and PCI of those patients always carries the risk of extending the dissection, as happened in this patient, causing also hemodynamic compromise. This patient required VA ECMO cannulation. There is a classification for dissections. It's the NH-LBI classification that breaks dissections down to 6 types, starting from type A, which is a minor luminal haziness, type B, which is a linear dissection, C is extraluminal contrast staining, D is a spiral dissection with extensive contrast staining of the false lumen. E is a dissection with a persistent filling defect, and then F is dissection causing complete cessation of antegrade flow. What are the causes of dissection? One of the most common ones and one of the most significant with potentially profound consequences is injecting when there is dampened pressure waveform. And that is why before injecting, as well as after injecting, the person injecting contrast should always check the pressure waveform and never inject if there is dampening of the pressure. The dampening may be due to non-coaxial position of the guide. It may be due to ostial disease in the vessel that has been engaged. There are many potential causes, but whatever the cause is, injection should not happen, because this is the way to lead to some profound dissections that happen in the proximal part of the vessel and can lead to acute vessel closure with dramatic subsequent results. There is also dissection that can happen when we're injecting through a side hole guide, and that is why I would personally recommend to never use side hole guides for unprotected left main, because they can provide a false sense of security. You may see a good pressure waveform because of the side holes, even though the guide position is not perfect, and then with injection, one can still have a significant dissection. Dissections can also happen during wiring attempts, especially through complex lesions. They can happen during balloon angioplasty, atherectomy, or if balloon rupture happens. They are more likely to occur in vessels that are heavily calcified or tortuous. Dissection can happen after stenting, and again, some patients might present with spontaneous coronary dissection. As we discussed before, the main way to prevent dissections due to contrast injection is to never inject unless there is a non-dampened pressure waveform, and then to avoid aggressive wiring maneuvers, avoid oversizing balloons and stents and using very high inflation pressures, and adequately preparing heavily calcified lesions prior to stent implantation. This is an example of pressure dampening. When pressure dampening occurs, there should not be injection of contrast, because this is likely to lead to dissection or other complications. This is an example of a patient with a right coronary artery CTO. And this was the first injection. The patient was referred for CTO PCI. The first injection was done, there was pressure dampening, but unfortunately that was did not stop the injection, and now we have a pretty extensive dissection all the way to the distal right coronary artery. Now in this case, and that's the advantage of understanding CTO PCI techniques, we were able to advance a guide wire do the distal true lumen, stent it, and get a nice final result. But once again, unwanted dissections during any PCI should be prevented as much as possible. The consequences of dissection in terms of impact on hemodynamics, causing myocardial infarction and arrhythmias, depends, number one, on the location of the dissection. So the more proximal, closer to the ostium of the vessel, especially the left main, the more likely to have significant hemodynamic consequences, and also the severity of coronary flow obstruction. If it's a complete cessation of flow, there will be more rapid and more pronounced hemodynamic consequences. On the contrast, some small dissections may not require any treatment. Sometimes these are found if imaging is done with OCT that is very sensitive for detecting these very small dissections. This is an example of a proximal right coronary artery dissection in a non-dominant right coronary that has a preserved T3 flow, and in this case, no specific treatment was required. The patient had an uneventful recovery. How to treat dissection when it occurs? The key question is whether we have a guide wire in the vessel or not. If we do have a wire, that facilitates things significantly because then treatment, which is stenting, can be performed without losing time. But if we do not have a guide wire, then it is important to advance a guide wire into the distal true lumen and confirm that the wire is actually in the distal true lumen, most often using intravascular imaging. If this can be achieved, then stenting is performed. If not, then emergency bypass may be needed, or in patients who have dissections in small branches, medical therapy may be all that is needed. Very important in cases of dissection is to avoid losing the guide wire. Sometimes in the panic that ensues when a complication happens and there is acute vessel closure, the wire can be inadvertently pulled back, and that is truly a disaster that makes subsequent treatment much more complicated. So if there is no wire in the lumen, the first attempt is to try to wire the true lumen. Don't inject contrast, because contrast injections can actually worsen the dissection. Another option, if a regular wire will not go, is to use CTO reentry techniques. So for example, the Stingray system or retrograde crossing if there are collaterals to the dissected vessel. And then again, if everything fails, emergency coronary bypass may be all that is needed. But typically, if one tries usually a workhorse wire and that can cross into distal true lumen, that would be great. If not, the Stingray system can often be very useful for re-entering to the distal true lumen. So these are some cases that illustrate management of coronary dissection. This was a patient with significant disease in a large right coronary artery. The lesions were predilated, and then predilatation actually caused some dissection, but no problem because we did have the wire into the vessel. But then during attempts to deliver a stent, there was difficulty, and what we were discussing before happened. Actually, the wire position and the guide were both lost. The patient had severe chest pain and ST segment elevation, and then we could not get through the right coronary again, which now had this dissection. So how to approach this problem? And this is an example where CTO techniques can be useful. In this case, we were able to advance a Stingray balloon and then perform re-entry to the distal true lumen. And after doing that and confirming distal true lumen wire position, we were then able to change for a workhorse wire, place stents with a guide catheter extension, and restore undergrade flow. So CTO techniques can be very useful if rewiring through a dissection plane fails. And this case has been published. Going on to the second case, this was a patient who had a right coronary CTO. And then there is significant tortuosity on the left system. There's some disease in the mid-LAD. There was successful retrograde crossing of the RCA CTO. But then during the procedure, there was sudden onset of chest pain and hypotension. And the reason here is dissection of the mid-LAD, compromising undergrade flow in the LAD. And actually in CTO-PCI, any injury of the donor vessel can be a lethal complication because the occluded vessel is already not providing coronary flow. Therefore, the importance of the donor vessel is critical to maintaining cardiac function. So in cases like this, it is of paramount importance to act very quickly. In this case, there was ballooning and stenting. That's where the safety wire is critical. When going retrograde, a safety wire in the donor vessel can truly facilitate treating these complications. And then eventually, a nice result was achieved. The LAD was stented, flow was restored, and the patient did well. Moving on to the third case. This was a patient who presented with a significant disease into the proximal LAD. Radial access was used, engagement was challenging. You can see the position of the catheters is not coaxial. An XB guide was used to facilitate PCI of the LAD. And then suddenly the patient developed acute chest discomfort and ST segment depression, and the reason was a dissection of the circumflex. We can see contrast retaining in the false lumen. The dissection extends all the way to the left main. So this can be a critical complication. Fortunately, there was wire position into the LAD. And then using a workhorse wire, it was eventually possible to wire through the dissection plane into the circumflex, confirm distal true lumen position using intravascular ultrasound. And then we can see here when the true lumen, there's a large dissection plane around the lumen of the vessel. And then after that, we're able to place stents and restore undergrade flow, both in the LAD as well as the circumflex. So to summarize, dissection is one potential complication during PCI, but it can also occur spontaneously in patients with SCAD. It is critical to maintain wire position in the vessel if there is wire in the vessel when the dissection occurs. If this is the case, treatment of dissections is with stenting. If there is no wire, then attempts should be made to wire through the dissection, typically using a workhorse wire and having a non-very heavily engaged or deeply engaged guide position to avoid pushing the wire to the dissection plane, and then confirm distal true lumen position followed by stenting. But then if that fails, CTO PCI techniques may be able to be used to regain distal true lumen position. If not, then either emergency bypass is needed or medical therapy could be pursued in patients who have a dissection of very small coronary vessels. Thank you.